All right, this is chapter 3, the steps of the nursing process for fundamentals of nursing. So chapter 3 in your book, if you have those PowerPoints with you, or you can listen to this recording over and over. So just a little bit about the nursing process. So this chapter is going to help you throughout nursing. Even 35, 50 years into nursing, this is still going to be one of those foundations. Foundations is so important to get down because everything else builds from it. So if you don't have a good foundation, just like at a house, it will fall over. The same thing. Your nursing career will come apart at the seams. You may or may not even pass NCLEX if you don't have these foundations down. When you think about NCLEX, you think about minimally competent, literally. The NCLEX is only telling your institution that hires you that you are minimally competent, that you will not kill somebody, okay? So this is one of those ultimate things that you've got to have down. When you go to tests on NCLEX, when you go to tests, any test that you're taking, you need to be thinking about the steps of the nursing process and some of the ways that we get to why we do the things we do as nursing. So much different than a CNA, just doing activities of daily living, taking a vital sign. But the next step, what is the next step? And that's what you came to Arizona College of Nursing for, was to bring your knowledge to the next step. So that's what we're going to do this quarter, this semester. That's what our goal is to bring you from wherever baseline you have to the nursing beginning competent person, okay? So again, I just want to reiterate that these are not my slides. This is not my material. I don't own this material, and under the fair use, I am providing this lecture content only for my nursing students using this material. All content within is only for educational purposes for nursing students and does not or substitute for medical advice. All right, so if you look at this diagram, when we talk about what is the priority nursing action, whenever a test question is asking you that, whenever it says nursing priority action, nursing flow comes from assessment first, then we diagnose. And diagnose, I mean nursing diagnosis, not medical. So make sure that you understand that. You are not making a medical diagnosis. The doctor may give you a diagnosis, but that's not the diagnosis we're using. We're using nursing diagnoses. So those are a little different. But when you see an assessment, you make a diagnosis very quickly what you need to do. If that's airway, bleeding, breathing, circulation, whatever that is the problem from your assessment. That's when you diagnose it. Once you diagnose it, you plan. So what am I going to do about this? So you plan. Well, you're planning. In your planning, you're thinking about what's going to give me the best outcome. Okay? And then you plan from the outcome that you want, what interventions you want to do. So if somebody looks blue and they're flat in bed, my assessment is that they're having trouble breathing, that I should put up the head of the bed, listen to their lungs, snap on an O2 sat monitor, and turn on some oxygen. I've done all those things in my head. You may do things, but not actually think about the process you actually went through to get to that process, okay? So this is putting a diagnosis to it and then intervening, okay? Then you implement your plan, actually do the step, then you evaluate. So in my scenario of putting oxygen on, I look at the patient, I assess there's something wrong, I diagnose airway incompatibility, there's a big problem here. I tip him up in bed because I know being up in bed helps them to breathe. Then I put on an O2 sat. I listen to their lungs. What is this? I'm diagnosing still. Then when I turn on the oxygen, oxygen is an intervention. I've implemented my plan. My plan was improve oxygenation. If I put on 2 liters of oxygen, hopefully that's enough to get him through. After a minute or so, after he's taken some deep breaths, my head of my bed is up, then I'm looking at how did that work? Evaluation. So evaluation goes right back into that loop. We go right back again. If that worked, okay, now I need to call the doctor and get an order for my oxygen to cover me. Okay. Oxygen is a nursing intervention, but it also needs a doctor's order to be charged for the day. So if this was anxiety, I'd put up the head of the bed, I'd give them oxygen, they're better now, they stop being anxious. I still need an order, okay? So then I call the doctor, tell him what's going on, and he gives me a PRN order for oxygen whenever they get anxious. If it's truly, oh my gosh, they popped a lung, that might mean I need to go back through this process one more time and think about calling the doctor to come in and needle a lung, which means I need to put in a chest tube, okay? So this is the process you want to follow. Whenever you get to a test question, it's going to ask you, the patient is flat in bed and looks blue. What is the priority nursing assessment? The assessment for me would be, look at him breathing, he's gasping, that's a problem, put his head up. That's my assessment, okay? So let's look through that. In the next few slides, that's what you're gonna see here. So whenever I get a test question, I think to myself, did they already assess? Did they already diagnose? Did they already intervene? Or am I on evaluation? But ADPIE will always get you there. ADPIE, ADPIE, is assess, diagnose, plan, intervene, implement my plan, evaluate. So I'm always thinking ADPIE, 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 ADPIE. Okay? But some people say that it should actually be ADPED because after you evaluate, you are going to educate the patient, then document. So technically, it should be ADP, but ADPIE will get you very, very far in nursing, if you just remember this. So assessment, what does that look like? Collecting data, taking vital signs, taking an O2 set, that's data. Data is numbers, data is an assessment, something that I can see and record something's going on with my patient. So that's collecting data using an ongoing systematic process. You categorize that data. You say expected, unexpected, expected, unexpected. Okay, my patient's in with pneumonia. Do I expect his O2 sat to be 96? Yeah, he has a disease process. What I don't expect when I go in the room is an O2 sat of 88. 88 would be, oh my gosh, something's gone wrong, okay? So using that assessment that you have, you categorize that data, then you record that data. If you are a CNA, you understand this already. Think about it. You walk into the room, you take a set of vitals, what are you doing? You're taking those numbers, you're writing them down, and you're also thinking about and analyzing that data. Expected, unexpected. What do I do about it? If it's within normal limits, I leave it alone. I continue to monitor. If it's unexpected, that's where I need to start going down the other holes, the diagnose, the plan, the intervene, and the educate. Okay? So that's kind of what it looks like. What's the difference? A medical assessment focuses on disease and pathology. We are not medical people. We are nurses. We're nursing. Nursing focuses on the client's response to an illness. So when we talk about assessment, a nurse does a different assessment than a doctor. A doctor wants to order the right labs, do the right treatments, A nurse is doing the right treatments as ordered by a doctor. We have a lot different focus to us. A physical therapist does an assessment. What is his assessment on? His assessment isn't on lung sounds. His assessment is on how much they're walking, how much assistance they need to walk. Okay? A therapist's assessment is different. A respiratory therapist doesn't look at everything. He doesn't care about the swelling in his toes. That's nursing. A respiratory therapist listens to the lungs, figures out if that's the right medication or should we ask for something different. Is that the right setting on the ventilator? Okay? So everybody's doing assessments, but we all have our own focus. So that's why you need the entire team, because we're all looking at different parts, and if we all talk to each other, we can all share what we're seeing in our perspective. A nursing perspective is going to be, are they getting better or worse? It's the response to the illness, or helping them not to become ill in the first place, which is prevention. Okay? So, how do we use the data? Well, we definitely want to document it because other people will also be looking at it too. Like I said, other disciplines are going to be looking at our assessments as well. We don't want to just chart what we think they want us to say. We want to chart what we actually see. So that's why it's important to do your own assessment and don't look ahead to who did what last time. Form your own assessment. Things can change rapidly. Do not copy and paste somebody else's column. The data is used to plan care. If we know that the O2 sat is 88, we know that we need to do something, and we're probably going to keep that oxygen on until we can maintain an oxygen sat of over 90% on his own. Much less 98% would be great before we go to room air. Okay? But every patient is different, so we have to make sure that our plan is based on the patient. If you have somebody with COPD, chronic obstructive pulmonary disease, we never expect that patient to be at 100%, nor would we want them to be. Their disease process shares with us that they cannot be at that high of a level. Them being at 90 is goal, or 92 is goal. That's the best we can assume with a COPD patient. So, to ensure the client receives the proper care by qualified individuals at the right time, that is the goal of the data. So, by qualified individuals, in my case of an asthmatic, I want to make sure that the respiratory therapist comes to see my patient, gives them a breathing treatment. That will help us to make sure that the patient's getting better. They're going to do their assessment, I'm going to do my assessment, and at the right time. So if somebody's having an asthma attack, you want to get everybody involved there so that we can all form an assessment and get the patient what they need when they need it. So, Socratic reasoning, you're going to hear that a lot this quarter and in the immediate semesters after this too. Socratic reasoning says, give an example of how a nurse might use assessment data to ensure that a patient receives proper care. How would you use data to make sure that they receive proper care? In my assessment, if I cannot get the patient out of bed, don't I want to provide proper care and get the doctor to also understand this and give me an order for a physical therapy consult? Because I look at the long, lifelong view of this patient, and if I know I'm going to send him home in 2 days and he can't walk and he can't even sit up in bed, how am I going to send him home? Okay? So think about ways that we use data to make sure that they're getting the right care. Nurses can't do everything. Nurses did not go to school to be physical therapists. Nurses did not go to school to be an occupational therapist. Nurses did not go to school to be a respiratory therapist. And nurses did not go to school to be a medical provider. If that's what you wanted to do, find that track. If you are with me wanting to help somebody throughout the lifespan recover from illness, prevent illness, that's what nursing is. And this is what we use to make sure that we're doing the right thing for our patient. So you might say, well, how can I delegate assessments? A nursing provider must perform the assessment portion of the nursing process. Now, what does that mean? That's where it gets fuzzy. An assessment has to be done by a nurse. A CNA or UAP cannot do an assessment, but there are pieces that we can delegate if they are a task. Okay? So, an LPN does not assess. What that is called is collect data. Can a nurse, an LPN, go in the room and listen to lungs? Absolutely. They are not doing an assessment. They are doing data collection. Only an RN, a registered nurse, can make an assessment. What's different between their assessment and mine? We're putting the stethoscope in the same place. We're hearing the same sounds. But a registered nurse is the one who can make the assumption or the assessment. Is it sounding worse or better? Does this sound different? An LPN is only coming back and telling you what they hear. It's clear, it's crackles, but they do not have the knowledge to understand the assessment part of it, meaning making a diagnosis from what we hear and what we see. Okay? So a nurse aide or an unlicensed assistant personnel, an LPN, they collect information, vital signs, pain reports, blood glucoses. That is data collection. However, it's the responsibility of the registered nurse to assign those tasks, validate the data collected, and conduct the interview and complete a physical assessment. In places that there are lots of LPNs, at least once in 24 hours, an RN has to assess that patient. So in nursing homes, there is an RN at least once a day on shift. They are responsible to assess every single patient and document that assessment. An LPN can take care of a patient and a patient load, but an RN is the one that actually assesses for the day. Okay? So if you're in a hospital and you have LPNs in use, they are taking care of the patient upon delegation from an RN, and they will chart as an LPN, but they are collecting data. If there was something wrong, they would come to you to find out what to do. Okay? So that's the difference. If you ever wanted to know, what's the difference between an LPN and an RN? An RN takes unstable patients. An LPN can only take stable patients. Okay? What's the difference between an LPN and a UAP? An LPN can do more for you, like pass meds, do wound care, put in a Foley, things like that, that a UAP cannot. UAP, CNA, just consider it activities of daily living. Okay. This will come back on the endpoints. So safe and effective care, that's the whole purpose of our goal in nursing, right? We don't want to provide ineffective care or care that's going to hurt someone. So that's when you get the thinking, doing, caring. That's what's different about nursing versus medical. We think, we do, we care. It's the responsibility of a professional nurse to assign those tasks, validate the data collected, conduct the interview, and complete the physical assessment. Resources to guiding nurses in delegation. 1 second. Okay, sorry about that. I had to pause that for a minute. My phone was ringing. Resources to guide nurses in delegation. So how do we know what we can give and can't give people to do? Well, there's state board of nursing acts, right? So every state says that people can do different things. In some states, an LPN can start an IV. They would have to have extra training and certification on that, but they could do that. Think about your techs in the ER. They are considered CNAs, or they may be a paramedic. They are on a different act of nursing. So they're on different practice acts, okay? So everybody has their own practice act, and you need to make sure if you're going between states, like I did as a travel nurse, that you look into the state's practice act before you go there and before you start taking care of patients there, because it's a huge difference between Florida and New York based on the practice act. The practice act tells you what you can and cannot do in that state. Agency policies and procedures, accrediting agencies, and the ANA. So, agency policies and procedures means my hospital, my nursing home, okay? Everybody could do a different thing based on the facility that they work at. So don't think if you go from daycare to HCA that you can do the same things that you thought you could, much less in a different country, right? So we had a nurse, a midwife, that ended up losing her license in Texas because she was a midwife in Germany. Well, what they do in Germany is totally different than the US. And I don't care who you are in Texas, you are not putting in an IUPC, whether you know how to or not. That's a provider that does that, okay? So that's an example of something that you don't do those things until you know, right? So you make sure. Accrediting agencies also tell us what we can and cannot do as a nurse, a doctor, a physical therapist, whoever. It's the state and the facility that tells you what you can and cannot do. Please make sure that you know what you can and cannot do before you go do it. There is never a problem saying, hold on just a minute, I need to check. There is a problem with saying, well, sure, I'll do that, and never having an orientation to doing what you're doing, okay? So just be very, very careful. The other resource we have is the American Nurses Association. They are a group of nurses that get together and decide on different scopes and standards of nursing. You will come back to see this in Nursing 213. When you come to see me in 213, we'll talk more about nursing practice acts and the ANA. So that's some guidance that we get on what we can and cannot do. So again, back to the data. What data do we have when we're data collecting? Okay, so subjective, think subjective. I say, I'm the patient. I say about my body. So pain is a subjective thing. I could say in the chart objectively what's observed or measured. I can say the patient is squealing in pain. I can say they are crying. I can say they are anxious, appearing anxious, hyperventilating. I can say their respirations are 27, but I cannot say there's no pain. Pain is what the patient says it is. It's the biggest problem that we have in nursing. You cannot say a patient's not in pain. Pain is what they say it is. If the patient tells you, I'm not in pain, you can chart patient states not in pain. Remember that there are cultural differences with pain. So the German might be stoic and says he's not in pain. We chart that he says he's not in pain, but we also observe what's happening. Tense muscles is observed. Blood pressure is measured. So we have things that we can say about what they are experiencing from the numbers or the observations, but we also must say what they subjectively say. Okay? So if you walk in the patient's room And you say, "Hi, how are you doing today?" And he's like, "Oh, not so good. This is the worst pain of my life. Oh my gosh." And he's crying. You chart and you chart what you see and what they say. Primary, obtained directly from the patient. The patient told you, "I'm in pain." Secondary would be something secondhand through the medical chart or through another person. So, if the patient is comatose and they have their toes curled, and the daughter says to you, "I think dad's in pain, look at him," that's secondary information. Primary from the patient, secondary, tertiary from other people. If I have a patient who's comatose or not with it right now or intubated, I cannot get primary information from my patient unless they're writing on a board. If they cannot talk to me, they cannot tell me, stroked out, intubated, something like that. I've got to take secondary information, and that might be from another person, or that might be from looking in their medical history. I have secondary information that he has had a closed-head injury in the past. Okay? So that's what that's about. And then when we're doing our nursing assessment, there's some skills that we're going to learn this semester. And in the sim lab and in the lab, that's what we're going to be practicing. There are specific observations. There are specific physical assessments. There are specific interviewing skills that we'll be working on this quarter. Okay? It's all in how you ask it, right? If you say, "You don't do drugs, do you?" has a different flair than, "Are there any illegal substances that you use?" Okay? Physical assessment, you are also in 216, right? So you know physical assessment, head to toe, you're going to be doing that. Observation skills, temperature, blood pressure, skin integrity, warmth, right? Things like that. And that's what we're going to work on this quarter. That's what you're going to learn, those basics. So some techniques that we use. When you think about skin or bowel, that's when this comes into play. So you always want to inspect. Inspect means hands off, look at the skin. Does it look weird? If I have a rash, I pull up their gown after I ask their permission and I inspect first. Do I not do this every day? When my kid has a rash on his arm, what do? I pull up his shirt and I look at it, right? Then what's the next thing that I do? I feel it. Does it feel like sandpaper? Is it bumped up? Is it raised? I feel, palpation, feel. Percuss. Percuss means I push on it. And then auscultate means listen to. Okay, so obviously skin, you're not going to listen to it because there's nothing to listen to, right? But think about this as veins. If you were doing a pulse, what are you doing? Okay, so look at your wrists. Think about this. When you go to do a pulse, you look at the skin. There shouldn't be any pulsing, I hope. But you're inspecting it first. Then you palpate it. You put your fingers on. You're feeling the pulse. Okay? Percuss is more like using your fingers to feel. So when we talk about, in physical assessment, when we talk about percussing lungs or percussing bowel sounds, okay? Percussing over the liver. Percussion is from the standpoint of either it's dull or it's full of air, okay? If it's dull when you hit it, it's full of fluid. If it's, what's the difference between dull and consolidation is dull. Hyperresonance Hyperresonance means air, okay? So when you percuss, you feel, okay? And then when you auscultate, you put on your stethoscope and you listen for vowel sounds, okay? Now, most of the time, if we were doing a lung exam, we're going to look at the patient and see their symmetrical breathing from their back. We say, okay, I'm going to listen to you for a minute, just a sec. You're looking at their lung expansion. Are both lungs expanding or is only one? That's a problem. This is what we are assessing when we're looking at a patient. So inspect the lung, then you palpate. So typically, think about it. You put your hands on their lungs, and you will hear this during physical assessment. You ask them to breathe in a couple of times. You put your hands on the sides of their lungs, and you feel a couple of times that they breathe. Are you feeling anything? Think about when you had pneumonia. You would feel that through your fingers. You would palpate that through your fingers. Okay? So on a patient with pneumonia, it's known that we would hear fremitus or feel fremitus. So on a pneumonia patient, you put your hands on them and you say, blue moon, say blue moon, say 99. You will physically feel them say that word through your fingers. That tells you that they have pneumonia because there's consolidation in the lungs making that happen. Do it to a normal person who doesn't have pneumonia, and you will not feel 99 or blue moon because there is no consolidation. It's all air. The air takes those waves instead of the liquid in the bottom of their lungs. Okay? And then obviously auscultation, you're listening for lung sounds. Okay? The only way that this is different is on vowels. Let me talk to you about vowels. When we get through this quarter, when you get through this semester, you're going to understand this better. Vowel sounds, you want to inspect their belly, you want to auscultate, then you can palpate and percuss. Why is the vowels different? Think about it. If I start messing around with somebody's vowel sounds, pushing in on their vowels, I'm going to cause it to start moving. I want to listen to them first, then palpate. So whenever you're really constipated, people will rub their stomach. That's why they're trying to get it to move. Okay? So you want to auscultate vowel sounds before you percuss and palpate. Okay? So typically we do it in the order of inspect, palpate, percuss, and auscultate, except in vowels. In vowels we inspect, auscultate, palpate, percuss. Okay? Okay, so again, what kinds of assessments do we do? We do them all the time. Different ones, different reasons. So a full head-to-toe assessment is an initial assessment. You should do a full head-to-toe assessment on everybody the first time you've ever seen them because you're getting a baseline. Then, if your facility says that you need to do an assessment once a shift, or you see something changing and you want to do another assessment to document the changes, you're doing an ongoing assessment. Okay? When we do vital signs at 12, 4, 8, those are ongoing assessments, continual assessments. A comprehensive assessment is full head to toe. Think about that as a sports physical. A focused assessment. New nurses don't get this. There is a difference from going for my annual physical, and there's a difference between I have a stub toe and they look at my lower extremities. A focused assessment. Think about focused assessment. If I'm here for asthma, do they really care about my skin Probably not. Okay? I'm worried about the lungs. Okay? So we do a focused assessment when there is a focused problem. In the ER, you will not see somebody do a full head-to-toe assessment most of the time. That's for the nurse practitioner. Okay? We do an assessment on things that are most necessary. Yes, we're going to do a head-to-toe assessment, but it's going to be a very not in-depth one. So when I do a head-to-toe, I'm not looking at their hair. Is their hair dry? Do they have any bumps, lumps? Do I look in their ears? No, I don't do that. I do eyes, ears, nose, and throat. Eyes, nose, stick out your tongue. That tells me moisture level in their mouth, dehydration, right? I listen to the lungs. I listen to the heart. I listen to the bowels. I ask them when they're last peed and pooped. I go down their legs. I make sure their, reflexes are fine. We're done. Okay? But there will be times where you need to do a focus assessment or a special needs assessment. Okay? So think about this. A patient comes in and they hit their head. I'm probably going to do neuro checks. Okay? That's a special need assessment where I go in and double check that their eyes, their pupils, right, curl up, pupils equal and reactive to light, okay, accommodating. I check their pulsing towards me, away from me, making sure they have strain, okay? So there will be special assessments along the way as well. Okay, every quarter when you go into a different kind of nursing, there will be special assessments to do. OB, for example, we don't do a full head to toe. We do a bubble bead. It's a very special assessment just on what we need to know. Okay? So some special needs assessments, so some different people might be coming in the room to help us with these. Nutritional assessment. That's a special assessment that gets done by dietary. Do I look at their nutrition? Yes. Do I do a full head-to-toe nutrition assessment on every patient? No. Okay? If I know there's a wound, I tell them drink more protein. Make sure you eat iron-rich foods, right? Pain. Pain is a special assessment. If somebody tells me the patient's in pain, they come back and they tell me, he's saying it's a 6. That's about all they're going to do, nursing-wise, right? CNA. What my assessment needs to be is duration, quality, quantity, constant, what does it feel like? I go a little more in depth. Cultural assessment, that needs to be an RN because you're culturally looking at the needs of this patient. Are there special dietary needs? Are there special prayer needs? Are there special whatever it is? Spiritual health goes along with that. Is there a special faith person that I need to call? Or can they get a hold of? What do I need to do to make this person whole? Okay? So holistic health, HOL, not WHOL. Holistic health, I'm looking at all of these things. They all play a part in my assessment as a nurse. They may not pay attention to that as a CNA, a UAP, an LPN. Okay? So psychosocial, I'm looking at psychologically and socially, how is my patient doing? This is where I notice that they're depressed, they lost their wife last month. That tells me that I probably need to do a little more assessment on depression, getting them into services, making connections for them. Wellness, so every once in a while you'll see like a wellness exam, wellness visit, OBGYN once a year, wellness. Are there wellness needs that I need? Are there family needs? If a baby is not going home with mom and dad, they're going home with another person, I might have special needs for the family assessment. I might want to diagnose what's going on with this family, why they can't have their baby at home. Community assessment. So we'll talk about that in public health especially. It's really good to look at your community. Thinking about where is the hospital, where is your sources for food, where's your sources for gym, the smog level, right? There's a whole bunch of stuff to think about with communities. If you realize that the patient lives in Fletcher Avenue, what's that community like? Okay, so you're looking at the overall. Is there faith community? Is there people in the community that can help them? Is it a rural area? Is it an urban area? Are there enough fresh fruits and vegetables available? Do they have to take a bus? Right? So all of these things come into play. A patient is not a patient, they're their entire community. And that's how you have to think about it. If there's something going on in the community, COVID, flu, strep A, that's another part of nursing, looking at what's going on in the community that's making them sick or making them well. Functional ability. If I have problems with functional ability, whether that's physical ability, functional mental ability, functional physical, mental, social well-being, that's what I need to know. Are they able to do the math? Are they able to count money? Are they functionally able to care for themselves? Okay. All right, so when you go in to see a patient at the nursing homes that we have planned for you this quarter, you are going to have to interview some people, especially a patient. That is the biggest thing during COVID that we went wrong. Nursing students couldn't talk to patients. You've got to be able to talk to people, right? And you've got to be able to get to really nitty-gritty things like sexual history very quickly. If a mom comes in labor, I can't be shy, but I have to have a mannerism about me that wants her to tell me what she needs to tell me too. So if somebody just did drugs, I need to know because it's going to affect my baby. I need to know how to communicate very effectively, very purposefully to get what I need. Okay? I would love to spend 3 hours with a patient getting a full medical history. That's just not possible in the hospital. You have 5 to 6 patients, right? So when you go into doing a nursing interview, hopefully they find you somebody that's really good at talking, right? Because they're the best patients. But you also have to realize that you were there for a reason and you need to stick to it too and communicate as well. Okay, so it's a purposeful communication, structured communication. You have a list of things to ask somebody. It involves questioning the client, which potentially could also mean a loved one. Who's a reliable source? If the patient is not reliable, then I'm fine with secondary information. There are times where you need to tell the secondary person to get lost and go get a cup of coffee. Not in that manner. Okay? So the purpose is to gather subjective data for the nursing health history so that we know what's going on, so that we can better plan their care. So it's a directive interviewing type, and then there's non-directive interviewing type. So if you think directive, it's, did your mom have cancer? Did your mom have gallbladder surgery? Did your mom have, right? It's going through a list, and it's yes or no. Directive. Non-directive is more therapeutic communication, needing more information. It's not a yes or no. It could be black and white and gray and polka dots all over. Okay, so if I talk to somebody about their mental health, am I going to say, are you seeing people? No, that's not what I'm going to do. I've got to kind of go non-directly through a conversation, gain support and a rapport with them before I ask them those really blatant questions. Okay, so we're going to work on this quarter. Preparing for the interview. So know the purpose of your interview, know how the data is going to be used. That's usually the opening line for you. Hey, just here to admit you, I got a couple of questions to get a little history from you. We're going to use this to plan your care better and make sure you're right on the meds. Okay? You read the patient's chart first, you form some goals and opening questions, and then you schedule uninterrupted time and have your forms and your equipment ready. So that's usually opening up your computer and going right down through the list. Compose yourself before you enter the room. You cannot do this if you're like, oh my gosh, I can't do this, I can't do this, I can't do this, right? You need to be in the right mindset when you go in there. So you can't say, oh my gosh, I gotta go check this blood in 15 minutes over here. No, wait until you get your 15-minute blood check done and then go in the room. Okay, so it should be uninterrupted time. When gathering assessment data, a nurse obtains a weight of 200 pounds. The client states, I've never weighed that much. What should the nurse do? So, question, what data have you collected and what would you do with them? Explain to the client how weight gain occurs. Check the calibration and reweigh the patient. Document the weight as 200 pounds. Or instruct the UAP to reweigh the patient in 2 hours. What do you think you should do? If the patient says, oh my gosh, my blood pressure's never been that high. Oh my gosh, my blood pressure's never been that low. Oh my gosh, your scale's off. Don't you think we should recheck our equipment first? Okay? Always double check our equipment. If somebody tells us we're way off, double check first. Okay? So the first thing we would want to do is go ahead and validate our data. Then, if there is a mismatch and we know our equipment is working, then we can talk to them about other reasons why they could have gained weight. Okay? Always validate your data. If you get a low blood pressure, look at the patient. Do they look low blood pressure? Look at the patient. Do they look high blood pressure? Is it my equipment? Should always be the first thing. If I see somebody has an O2 sat of 88% and they're pink, and they're not having trouble breathing, maybe I need to take off the O2 sat monitor and look at their nail polish and say, okay, my bad, should have told you to take off the nail polish. Okay? Get a high blood pressure. Are their legs crossed? Okay? This is where you need to go. A CNA collects data and documents it. A nurse looks at the data and says, what? That's not right. Critical thinking, okay? Critical judgment. If somebody says, my pill is usually purple, why is it pink today? Stop, check, ask which medication they're talking about, do a little more investigation. We might be wrong, okay? So validating data, great point. If the subjective and the objective data do not agree or do not make sense, like my German patient who's in pain, but he won't tell me he is, and my blood pressure is telling me something different, sometimes I need to think about why the statement might differ at different times in the interview. Data might be far outside the normal range. Anytime factors are present that interfere with accurate measurement, fingernail polish, okay? Always validate if something seems off, okay? The client's statement differ at different times in the interview. No, I'm not in pain. And then they start crying 10 minutes later. What's your pain now? Should be a key indication, okay? Things can change throughout the interview process. Also remember that sometimes people are pathological. They're showing you there's a problem because they want to get into the ER. So they might, and then you get them back to the ER and they're not having trouble breathing anymore. Just saying. Validate your data. Garbage in, garbage out. Guidelines for documenting data. You want to document as soon as possible. You want to write neat, legibly. in black ink or record the data. How many times do you get a piece of paper towel wadded up in your pocket and you can't even remember which patient that was? Take the 2 seconds and get the computer on wheels and document it. If it wasn't documented, it wasn't done. Document it. Document it electronically. It doesn't matter if it's on that sheet of paper when the patient goes to the OR. It makes a difference if it's in the electronic system. Document as real time as possible. It'll save you a heck of a lot of trouble. Use proper spelling and grammar. This is why all along in nursing school we have been sticklers, especially me, on APA. What does it feel like if you can't even spell and you can't use appropriate grammar? I'm not going to necessarily trust your assessment if you can't spell correctly, okay? Now, in the computer system of things, that's usually not a big issue because most things are drop-down menus. But you should take a minute and double-check that it is right and double-check it and not use LOL and things like that, okay? Okay, use acronyms sparingly. Okay, don't want to use an acronym unless everybody knows what it means. What I use for short of breath might not be what other people use, or I might be in the wrong country for that. SOB, if a patient's reading their chart, might not make the same sense to them as shortness of breath, okay? Write the patient's own words when possible. I cannot stress this enough. And put quotations around them. This will save you in the long run on the court stand. Okay? So if you're having trouble with a patient, it's okay to put it in quotations. It's okay to do that. You want to use the patient's own words, not give them words, and not make assessments or assumptions, because we know what assume means. Record only the most important patient words. You can use quotations around those important words. Use concrete, specific information. Record cues, not inferences. Cues are things observed. Inferences are assumptions. The patient was anxious. That's an assumption unless they tell me that. Okay? The patient was heavy breathing. The patient was tachycardic. Record cues. Okay? The patient's depressed. What does that mean? Okay? Don't use words that can be misinterpreted. All right, organizing that data. We use a few different things. We use functional health patterns. We use NANDA. We use Roy's adaptation model, Orem self-care model, and then also with non-clinical, non-nursing model that we use a lot is Maslow's hierarchy of needs. We're going to talk about that a little bit later as well on day one, because Maslow's hierarchy of needs gets us a lot of places. Now, if you look up Maslow's hierarchy of needs, the bottom level is food, water, sex, shelter, just the basic minimums. Think about when the hurricane hit. Were you worried about going to work? Were you worried about... No, you weren't worried about that. You worried about food, water, shelter, safety, sleep. How am I going to be safe? Okay? Then you work up the chain. Okay? So Maslow's will make a lot more sense later on here. So, tools for diagnosing and recording that assessment data that we find: graphic flow sheets, I&O sheets, nursing assessment sheets, nursing discharge summary, special purpose forms, electronic documentation. We will be using the EHR in ATI quite frequently this quarter to get you used to it. There is a lot of electronic documentation that we can do in the sim lab that mocks the real work environment for you. So we'll be going through that. So reflect on your assessment. So again, just like every other communication that you have, don't you always ask yourself, is it relative and is it nice? Is it needed? Right? Same thing. Are my data complete, accurate, validated? Did I record it? Did I record data and cues, not conclusions, not assumptions? Did I follow up with special needs assessment if indicated? If I notice that my patient's pupils are different sizes, it would behoove me to do a neurovascular assessment. Think about the client interview. Did I document everything? Review your physical assessment, your observations, your examination. Make sure you document everything. If it was not documented, it was not done. Okay, diagnosing. So, when we talk about diagnosing, they are health problems. They are not diagnoses. So, what could I say? I cannot say pneumonia. I can say ineffective airway clearance. I can say ineffective airway circulation. I can say lots of things, but I cannot use a medical term. There are conditions that require intervention to treat a disease or an illness, and the treatment could be independently or collaboratively done. So treatment independently, put their foot up if they have swelling in their foot. I can independently do that. But there might be something I have to do collaboratively, like breathing treatments, oxygen, ventilators, that I need a respiratory therapist for. And I need the doctor to write those orders for me. Nursing judgment, nursing orders do not need a physician's order to do it. Putting a foot up on a pillow, do not need an order for that. Okay? So nursing diagnosis has come from a nursing focus. It's a clinical judgment about an individual, family, community, response to actual or potential life problems and life processes. I don't want you to get too overwhelmed by this right now. This will become clearer during the semester, okay? Collaborative problems. Are there problems that I need extra people for? Physical therapy, respiratory therapy, are there complications of diseases that I need? No doctor, no medical doctor is going to do medical by themselves. They are going to call in the surgeon to do surgery. They are going to call in the infectious disease doctor if there's an infection, right? So we work in collaboration all the time, okay? So a certain disease or treatment that's at risk for developing a complication. Asthma, I'm going to ask the allergy and immunology doctor to come see my patient. If I'm a general practitioner doctor, I know general, but I'm not deep into depth of anything, right? So nursing, consider it like general practitioner when you get out of nursing school. You are not good at any one thing. You're a jack of all trades. Then you find that thing that you love, okay? Always a potential problem. There's always a potential problem out there. That's why nurses are trying to figure out what is the problem so that we can fix it. So diagnostic reasoning, you're using critical reasoning, critical thinking to analyze and interpret the data, draw a conclusion about what the health status is, verify the problem with the client, prioritize the problem, airway, breathing, circulation, which is first. Discharge instructions are probably not going to be first. And then record your diagnostic statement. Okay? So, analyzing the data. Identify what's significant. Cluster your cues. So I call it blues clues, right? So blues clues, you're looking at all the clues and what do they mean? He's blue. His lips are blue. He's breathing heavy. He doesn't look good. His fingernails are blue. This is a problem. Here's my clues. I analyzed them and I said, I think this is oxygen. Okay? I didn't think it was circulation. I didn't think it was neuro. Okay? So you cluster what cues you have and make an assumption on what this is. You identify the gap, the inconsistencies, you draw conclusions about what the health status of the patient is, you make inferences, which are different than assumptions. Inferences, I think this is oxygen. Then you identify the problem etiology. They're wheezing. Oh, I bet this is an asthma attack. And then I ask the patient, have you been around something lately that you're allergic to? And when they say, yeah, I went to the pool today, I'm allergic to chlorine. There we go. So you're prioritizing problems. Prioritizing problems in an asthma attack with chlorine, think about it. Even when you took BLS, didn't they tell you take the patient out of the area? But only if you could do it safely? So, how would you do this? You say, are you still in the pool area? Get out now. Get fresh air, right? If you're in your ER, you know that they're out of the environment. What are you doing? You put up the head of the bed because they're having trouble breathing. You listen to their lungs. You put on an O2 set. You get a set of vitals. You put on some oxygen, 2 liters. Then you call for extra assistance because you probably need an albuterol treatment, but that needs a doctor's order. Okay? So, it does not mean you need to resolve one problem before attending to another. You could be doing multiple things, but it is determined by the theoretical framework that you use. So, in the case of an asthmatic, telling them to avoid the pool is not first priority. That's discharge instructions. Okay? What is most important is airway, breathing, circulation. I want to give him oxygen, make sure he's breathing better after his albuterol treatment, and then I can worry about oxygen circulating better and his restricted airways opening back up. Then I can think about discharging him. Okay? So prioritization. What comes first? So Maslow's hierarchy, we talked about that a little bit. This often is used to prioritize our nursing problems. So we'll look at this more in depth on day 1. But down there on the bottom, food, air, water, shelter. Airway, airway, airway. If my patient comes in and tells me he cannot breathe, do I start doing safety and security? Do I start doing love and belonging? Do I do self-esteem? Do I do cognitive, aesthetic, self-actualization? Oh my gosh, no. He's at the bottom rung. There are days that I come into class and I'll ask you, what's going on? What's the beat on the street, right? Because I want to know, can I even get there with you today? Or should I go back down to the basics and just start from square one, because you're not able to listen to me, okay? If I'm not able to listen because I've been up all night having a baby, it's not the time to come in with the breast lady telling me how to breastfeed. I'm going to start crying, okay? So we'll go over this more this semester and you'll get this. But remember Maslow's when you get to a test question. The answer is discharge instructions. It's never going to be first priority. You can't get somebody to discharge instructions until you get them safe and secure and have food, water, and shelter. Okay? Problem urgency. So when you think about priorities, you get to a stoplight, right? You get to a stoplight and the red tells you high priority, I got to take care of it right now. A yellow light means it's not a direct life to threat, but it's more than discharge instructions. And then low priority is green light, leave it till the last minute. It's not priority intervention right now. Okay? So, high priority, life-threatening. So if I had 4 patients in the ER and one is an asthma attack turning blue, life-threatening? Heck yeah. Somebody with hemorrhoids? Not life-threatening. Okay? Even on your med pass, think about things. Which is more important, a once-a-day vitamin C or an antibiotic for somebody who's septic? Okay? There you go. Patient preference. Assign high priority to problems that the patient thinks are most important if they do not conflict with basic needs and medical treatment. So, patient comes in and they're worried about the tightness of their socks. They're swollen. Take off the socks. If that's what they're worried about, take off the socks. You're still in the right direction. Okay? The statement, which statement is a priority nursing diagnosis? Priority, priority, priority. So think about it. Priority, life-threatening, impaired verbal communication related to altered CNS, central nervous system. Fluid volume excess related to compromised regulatory mechanism, too much fluid. Impaired physical mobility related to discomfort, broken foot. Activity intolerance related to generalized weakness. Which one sounds like a problem? If I went through here, A, B, C, airway, breathing, circulation, okay? So altered central nervous system makes me nervous, but is it life-threatening? That's a question. If my patient is having a stroke, their ability to communicate with me is not the emergency. Their ability to breathe is an emergency. Their ability to function is an emergency. A stroke is a CNS change. Anytime that it says obtunded, not reactive, unconscious, that would be a cue to hit that. See how they did it? So this is how they get you. They put CNS in there, and you didn't read the whole thing. A patient not being able to communicate with me verbally is not a big priority on my list. Impaired physical mobility. They can't move. But is there something ABC? Is there an ABC that's going to be a priority? Fluid volume excess means swelling, compromised regulatory mechanism. So if I consider that too much swelling goes from the feet to the hands to the face to the lungs, and I start filling my lungs full of fluid, that would be an airway issue. So a CHF patient, congestive heart failure, will always win from these four sitting in the waiting room. The person who is in trouble right now, life-threatening, is fluid volume excess. I need to pull that guy to the back. Fluid volume excess causes pulmonary edema, impaired gas exchange, and eventually respiratory failure. Fluid volume excess, therefore, is a life-threatening and high-priority problem. Then I'd probably take somebody else, right? Probably the altered mental status next, but not because he can't communicate to me, but rather that I need to see what's going on CNS-wise with them. Is it a stroke? What is it? Okay? All right. So standardized nursing language. We use standardized nursing language so that everybody understands impaired gas exchange is impaired gas exchange. Impaired gas exchange means that my patient's not getting enough air, oxygen, and they're turning blue. It clarifies communication about nursing knowledge, thinking, practice. My patient's turning blue and can't breathe doesn't really tell me as much. If I want to be seen as a professional, the minute that I say impaired gas exchange, everybody knows what that means right away. So the classification system, there's a lot of different classifications, especially when you get to mental health. You'll see like the psychiatric diagnosis and manual for mental disorders, CPT codes. So if you ever did any coding in your other life, you will know what those are. So there are different CPT codes, but again, these are a medical diagnosis. So when you look in the chart and you see hypertension, hypertensive crisis, those are medical diagnoses. Medical diagnoses draw these CPT and ICD-9 and 10 codes. We use NANDA codes. NANDA is the most common, so you should know NANDA. You should get a list of NANDA diagnoses. I'll show you that on day one, where to find that nursing diagnosis list. When you walk through that list, it basically tells you, and it focuses you on where you need to be. Is it impaired bonding? Is it impaired airway exchange? Is it constipation? What is the problem that we're having? And then writing quality statements. So this will be your nemesis for the next 5 quarters, 5 semesters, getting this right. It's not just putting stuff down on paper, but it has to be written correctly. So when you choose a label, don't look at the label alone, but it's got to fix the problem and the reason why, okay? So be sure that the etiology or the reason why is not just a restatement of the problem. Impaired gas exchange because they can't breathe. No, that's not the point. The point is there's a disease process there, okay? Avoid using medical diagnosis and treatment as etiological factors. Okay. Write it clearly, concisely, descriptive. We'll get to some of these in the next few weeks and you'll get it better, okay? You will get it better over time. Do not worry about it right now. So, think about some of the things that are related to outcomes and interventions. The problem suggests the outcome that you want, or the goal. The etiology suggests the interventions. Planning. When I plan, I put it down and I talk to my patient and make sure that they're agreeable with my plan, because what good is my plan if they're not going to follow it, right? Ongoing, I want to make sure that they're still with the plan. So this is nurse care plan. Discharge planning, we're actually starting that at admission when appropriate, but discharge planning causes a lot of people to have to collaborate. So you want everybody available, everybody's talking to each other, and there's a continuity of care and self-care that we have to think about. When they go home, how are they going to take care of themselves? So you identify those things upon initial assessment. I think he needs a crutch or a cane or a walker or a wheelchair. Those are initial assessments, and then needed by all clients, requires collaboration, and then addresses the special need of an older client. If they need whatever it is, a crutch, a cane, a walker, how are we going to get that equipment? How do we offer them a choice of getting that equipment? And how do we get it to their house, especially oxygen? Okay? This is where social work helps you. You can't do this alone. So social work helps figure out the insurance part of it and the logistics part of it. But we all need to be together to understand, because we need a doctor's order for that oxygen going home. That's why a written care plan is so important. It shows everybody where we're thinking, where we're going, and how are we getting better or worse. How is our plan? That's why written care plans are so important. People will say, oh, you will only write those in nursing school. No, you won't. You will be writing them. They are a requirement of the accreditation agency. They're a requirement for assessing and charting a patient's care, and they are the most effective use of nursing efforts. From your care plan, the charge nurse makes an assignment for the next shift. If they see that your care has gotten better this shift, they might downshift staffing. If they see that you're giving 3 blood transfusions over the next 12 hours, they might upstaff. So that's why these things are so important. So most of the time you're going to see computerized care plans. There could be critical pathways out there still. They're pre-printed, standardized plan. A 3-day post-op HIP. They should be doing the same thing every day. Every patient should be doing the same thing on day 2. Okay? Student care plans are more designed for learning. They contain a bunch of nursing orders and rationales and references and everything. You won't do that in real life. In real life, it'll be on the care plan. It's clicking boxes and then going back in once a shift and making sure that we're still on plan. So a nursing care plan is like maintain O2 saturation above 90%. You go in, you say met for this shift or not met for this shift. If it's not met for this shift, then you go ahead and write a note what you did, but on oxygen. If they're above 90, you put a little note, above 90, maintained oxygenation over room air for total shift. Then if it's not appropriate anymore, you took out the Foley, get rid of it off the care plan, right? So that's what this is about. All right, you make the problem list work, and then you decide if the problems are managed, and you individualize the standardized plan as needed, and then you transcribe medical orders to the appropriate document to make sure that you know that you've got all your orders covered for this. Now, individualizing the standardized plan, I'll give you the caveat. Joint Commission loves a standardized plan that's not individualized. You must individualize it. It can't just be on paper for everybody the same thing every time. So think about it. If my patient only had 1 hour of surgery and didn't have a Foley catheter in, why do I still have Foley catheter on my care plan? That's why you do these, okay? Write the activities of daily living and the basic care needs in the patient care summary. Develop that plan over time. Is there something else I need? Are they done that? Get that off, put a new plan on, okay? All right, goals and outcomes. What is the goal of putting oxygen on? To maintain O2 over 90%. That's a goal. That way we all know what we're fighting for. So if the patient knows that they have an order for oxygen less than 90 and they're feeling kind of winded, they would call you. You could observe if you need to put that oxygen on or not. Okay? Short-term and long-term goal. A long-term goal would be a week, a month, or more, weight loss of 10 pounds. Short-term goal, 1 pound a day. Okay? Exactly what it looks like. Outcome label, indicators, measurement scale. Think about this. Maintain O2 sat, indicator, outcome label, maintain, measurement scale. O2 sat should be above 98. Okay? So that is the components of a good nursing outcome. All right, so groups for wellness, things like that, demonstrates health maintenance, achieves an even higher level of health. Those would be for wellness. Avoid preventative, preventative maintenance is not what we want. We want to do the maintenance on our car, get our oil changed more frequently than 12,000 miles. So identify the nurse client outcome goal that is written correctly. The client's urine output will be adequate by the end of the shift. What does adequate mean? That's not specific enough. The client's pneumonia will be resolved as evidenced by clear breath sounds bilaterally by discharge. Okay, but I could do better. What if it's not? Is pneumonia going to clear up by discharge? They usually get discharged in 2 days. Probably not. A client will ambulate 20 feet in the hallway using a walker by evening shift tomorrow. Ooh, that sounds good. Who, what, when, where, how, why? That kind of answers everything. The client will drink more fluids than they did yesterday by 7 o'clock. Can I drink coffee? Does it have to be clear liquid? Clear fluid? It also doesn't tell me how much they drank by 7 o'clock yesterday. C is the answer. So you want something that is really good. It's accurate, right? So think about SMART goal. Measurable, timely, relevant, okay? Specific, okay? So we use SMART goals a lot. Does the client, family, or community value the outcome? If the patient doesn't value the outcome, do you think they're going to meet your outcome? If I like ice cream, do you think I care if you want me to lose 10 pounds by Friday? Not really. This is the question of making sure that it meets the outcome to the patient and the patient's goals. Make sure that it's patient specific, not what I want. It's not about you. It's all about the patient. You have written a tentative outcome for a client. You're not certain if the client values that outcome. Use thinking as part of safe, effective nursing care. Think of some client behaviors that might indicate the client does value the outcome. Yeah, I think I can do that. I'll be able to do that. Yeah. Agreement. You got to have their agreement, or else it's not going to work. Okay? Could they do it? So suppose a nurse sees one of your students' care plans and says, "You're wasting your time writing those things. We never use those in the real world." What would you say? Because I guarantee you they would. But we do. We do use these in the real world. They may not see them the same way as an experienced nurse, but they do, and it helps me with learning. Planning interventions. When you plan interventions, there is also classifications and languages that you need to use. These three are the most frequently used in health records. CCC, the clinical care classification, the Omaha classification, and the nursing interventions classification. It consists of a label, a definition, and a list of specific activities. So a nursing order contains a date, a subject, an action, verb, time, limits, and a signature. So a nursing order would provide goal-oriented centered care, establish mutual trust with the client, show respect for the client's values, religious beliefs, needs, and preferences, implement interventions to promote client comfort. So goal-directed, client-centered care, not nursing-centered. Validate evidence-based research to incorporate into practice. So it needs to be evidence-based. It can't just be what my mom told me. And then provide safe, quality care. So you want to be thinking, caring, doing. So think what's best in this situation. Maybe I need some evidence-based to figure out what's best in this situation. Caring, will the patient do it? Doing, what can they do to help? Write one intervention to address the problem and one intervention for the etiology. Airway clearance impairment, they can't get the crud up, related to thick secretions and decreased chest expansion, secondary to dehydration and pain. One intervention that you think might be needed here. Thick secretions, what do we tell people with thick secretions? Drink more water. Encourage fluids. Okay. Airway clearance impairment, thick secretions, decreased chest expansion. Chest expansion, pain. Wouldn't I also tell them to use an incentive spirometer and splint because of the pain, especially a post-surgical patient? Okay. Bathing, dressing, feeding, toileting deficient. due to fatigue related to secondary heart failure, fluid overload on the heart, self-care failure, so unable to do care, and fatigue related to heart failure. Two things that I would do. An intervention to address the problem. Don't do everything at once. Do it slowly. Take frequent rest breaks. Problem. Etiology of the problem. Heart failure. Heart failure. Do one thing at a time. Bathe once a week. Use a washcloth instead. Feeding intolerant. They can't get up to the kitchen to make meals because they're so out of breath. Meals on wheels, if they're acceptable to you. Otherwise, it might be microwave meals or putting meals for the week in the fridge. Okay? Implementing the nursing process. Use cognitive, interpersonal, psychomotor skills, promotes client participation, and coordinate the care. So when you implement the plan, transfer that responsibility to the patient, but you're still accountable for it. What do we say with the incentives barometer? We tell them, every time a commercial comes on, take 10 breaths. You're giving them responsibility, but you're accountable to make sure that they're doing it. Include supervision. So you supervise the first time they do it. You supervise every once in a while when a commercial comes on, when you're in the room. Are they doing it? So the key point is you can't delegate anything that requires independent, specialized nursing knowledge, skill, or judgment. Something an RN should be doing. Should they be doing it? No. Okay. Addressing change on a central line. No. Okay. 5 rights. When you think about delegating something, ask yourself, is it the right task, or should a nurse do it? Is it the right circumstance? They're going home, they have to learn it. Is it the right person? Have they been trained? The right direction and communication, and the right supervision. Do I need to be there or do I not? So a nurse reviews care meeting for a group of clients. Which task is inappropriate to assign to a UAP? So which one can the UAP not do? Make sure a client takes their pills after a meal. Ambulate a post-surgical patient to the bathroom. Bathe a client who is listed as a fall risk. Feed a client with severe visual impairment. ADLs. Ambulate a patient, yes. Bathe a client, yes. Feed a client, yes. Why is he giving pills? I don't even care if it says make sure they took their pills. If it says pills, that should be an LPN or an RN. That is not a UAP's job. Scope of practice. Make sure you know what you're asking people to do. I am not telling you you won't see this. I am not telling you that it's not a best practice. You will see tons of things out there. What you see and what you do are two different things. You will see a lot of things. You ask yourself, is that the practice that I want? Is that the practice that makes me a good nurse? Okay? Documentation, the final step. Document, document, document. If it wasn't documented, it wasn't done. You got to document everything. That's how you drop charges. That's how you keep your job, because the hospital keeps getting paid. Interestingly, oxygen is a charge once a day. And interestingly, it's tied to the documentation in the patient's chart. So if a patient got discharged at 1 a.m., we lose the money for that entire day if somebody after midnight did not walk in and document on 2 liters of oxygen. So a lot of the charges are dropped behind our documentation, and it's whoever drops that charge for the beginning of the day. At midnight, whoever goes in first, whether it's respiratory, whether it's the CNA, whether it's the LPN, or whether it's me, going in and saying they're on 2 liters of oxygen, that drops the charge for the whole day till the next midnight. Okay? That's why it's important. So you're evaluating your progress towards the goal, the effectiveness of your care plan, and the quality of the care that they are getting. So if their oxygen is 99 and they have been without oxygen all day, their progress towards the goal is going well. It's met. So you're looking at, is it met or unmet? So you're looking at the standards and the criteria. You want a criteria that's measurable, reliable, and valid. So an O2 sat of 98 is a valid measure. So what's being evaluated? Your structure, your process, and your outcome. If they're not able to keep their oxygen over 98, then maybe there's a problem with the lungs. Maybe there's a problem with my process, or maybe it's just not realistic. Maybe he needs to go home on oxygen. That's what you're doing. What is this type of evaluation? The nurse's activities in making a good diagnosis, recommending or implementing an intervention. Process, the nurse's activities in making a diagnosis. Process evaluation. The client's condition or well-being is improved. Outcome is better. That's an outcome evaluation. And then a structure evaluation is how everybody's playing along in this healthcare system. All members of the interprofessional team being used? Or did we forget somebody? Sometimes we forget to ask the respiratory therapist. All right. Ongoing evaluation. Ongoing means once a shift. I go in and make sure it's still okay. Intermittent means if something changed, I would want to drop another evaluation. Terminal means exactly what it sounds like. The end. Upon discharge, I need to go in and close all of my things. You can leave it ongoing, discharged home with ongoing care, plan of care, but you want to terminate your care plan. Terminate it when it's no longer needed too. If they're not using oxygen anymore, take that off, right? How do I evaluate clients' progress? Well, you have look at the outcomes, you look at the collection of reassessment data, O2 sats, you judge that outcome, is it met or not met, and then you record that. If you don't meet it, then you need to make a little more note of what are you going to do to change the plan because you have not met it. Okay? Evaluate, revise the care plan based on this. And then checklist for assessing, right? You assess, you're going to go back and look at, is my assessment right? Was my diagnosis correct? Was my planning outcome correct? Was my intervention correct? Was my implementation of that right? So if somebody's not doing something I told them to, it might not be me, but it could be me. Start with the equipment, right? Make sure that they're on board with this care plan. Okay, a couple more slides. Reflecting critically about your evaluation. Thinking about your thinking. Do I have stinking thinking? If I have stinking thinking, we're in trouble, right? So you inquire, is this the right thing? You notice cues and content. You analyze your assumptions that you put in that plan. Then you reflect skeptically what could be causing them not to get this. Sometimes it's a conversation with the patient. If they're like, no, that ain't gonna happen. Okay? And then QI, obviously, we're always in a quality improvement method of thinking in our head. So we're always thinking evaluate, improve, evaluate, improve. Is there something we can improve upon in our structures, in our outcomes, in our processes, in the healthcare system? Safe and effective nursing care, what you do as a nurse. Are you providing the most patient-centered best practice care? Are you employing best practices for fairness and inclusion? Did you forget that they don't eat meat? They're vegan? You forgot about that in your care plan? Do you strive to enhance patient satisfaction ratings? Do you ensure compliance with legal and accrediting regulatory agency requirements? Okay. This is what safe and effective care means. Doing what you can, doing the best you can, not just the 75% that gets you by. Okay? The 77% that gets you by. 77% is not worth it. Do not go into nursing for 77%. We need to be striving for 90, 95. Okay? All right. That is it.